Hit record. So in terms of a ligand, a ligand is a general term. And it's basically anything that connects to that receptor or enzyme or the binding site. So the body obviously has endogenous ligands, so substances that exist in the body that bind to those receptors, enzymes, or binding sites. Otherwise, it wouldn't spend the time evolving that thing. Um, but what we do is we take advantage of that by using exogenous ligands, meaning drugs, in order to manipulate what the body already has. Um, so my kind of example of this is the mu opioid receptor, which is um, we call it the opioid receptor because we discovered that it was uh, agonized by opiates like morphine. Um, but we know that there are endogenous chemicals that the body uses. And does anyone know what the chemical is that activates the opiate receptors in the body?
Nope.
They're the endorphins, the natural high, right? The thing that makes you feel good. So the endorphins are what activate the opioid receptor. And so what we found is that the we could give opiates and it happens to work on the same receptor. Um, Same thing for any receptor in the body. You have an endogenous ligand like norepinephrine or epinephrine, dopamine, serotonin, any sort of chemical in the body, insulin, um, and then you have some sort of exogenous substance that we administer as a drug in order to take advantage of that system and kind of push it more than it's supposed to. But that's a really good question. Um, all right. Uh, I feel like so ligands are endogenous and the drug is exogenous that manipulates what a ligand can do. No, a ligand is the thing that binds to the binding site. So a endogenous substance and a drug are both ligands. It's any molecule that binds to a receptor. So whether that's, part of the body already or we administer it as a drug. Yeah, I could have made that a lot clearer when I went through that explanation. That was my bad. But all right, so let's finish up with kind of the last stuff to talk about for the first exam. Um, and then we will go from there. Um, do, do, do. All right. So the last time that we met, we talked a whole bunch about when we were talking about pharmacology, I should say. We talked a whole bunch about types of drugs, their selectivity, their efficacy, potency. And one of the last things that we have to talk about is their uh, um, reversibility. And sorry, I'm just organizing all of my many screens. The reversibility and, of course, toxicity. Do, do, do. All right. All right. I want to take this graph. All right. This is page 26, in case people are curious. So what we're looking here is we have an agonist, which is the triangle, and then we have three antagonists, which is the circle, the square, and the star. Now, specifically, what's going on here is that we are giving the agonist, but we're also giving the antagonist in these other situations. So for the first column, we have just one drug, and for the second, third, and fourth column, we have two drugs that are being administered, and we have different doses of the antagonist. So 1 milligram, 3 milligram, and 10 milligram. What's important about this what's important to know about graphs like this is the shift along the x-axis. Remember that one of the ideas of potency is the milligram amount to achieve the same response. So what we see is that under normal circumstances, if you administer the drug, 5 milligrams will get you 100% of a response. So if you want to completely knock someone out with a benzodiazepine, or you want to block 100% of the pain, then you only need to give 5 milligrams of our drug in order to get the complete response. What we see is that if you add 1 milligram of the antagonist, you now have to go up to 50 milligrams in order to get the response. 3 milligrams means you have to administer 500 milligrams. And then 10 milligrams of the antagonist means 5,000 milligrams of the agonist. So what we are seeing here is it's almost as if the agonist is becoming less potent, right? But really what we're seeing here is just the antagonistic effect of adding an antagonist. And so what we can see is that there is a shift along the x-axis dictates potency. So the question becomes, is the drug less effective when you administer 5,000 milligrams with 10 milligrams of the antagonist? Is the drug less effective when you administer 5,000 milligrams with 10 milligrams of the antagonist? What do we think? Less effective?
No, it's just as it's effective.
Just as effective. And just like people are saying, you get to the same maximal response. So what's important to know about adding an antagonist is that an antagonist doesn't necessarily change what the efficacy of the drug is. Sorry, this bread is like way too dry. An antagonist doesn't necessarily change the efficacy of a drug. It can make it so that way you need, almost 1,000 times the dose, but it doesn't necessarily mean that if you give enough drug, you are going to have a certain percentage of the response. What about a situation like this? So again, we have percent max response, 0 to 100. And we have the dose along the bottom. This is drug A. And here is drug A with another substance. So the question is what is the relationship between drug A and other drug? Are they additive? Are they Oop, I have to add another line. Are they synergistic? Are they potentiated? Or are they antagonistic? Someone thinks potentiated, possibly. Not synergistic because they'd have to be the same. Yeah. Yep. I would say that is a fair.
Would it be additive? Sorry.
Let's see. So one of the charts that Keel gives you, and that if you look this up anywhere online, you'll find a very, very similar chart, is this guy. And it's this idea that additive is, 1 + 1 = 2. So the response of one drug plus the response of another drug is just the combined effect of both drugs. Synergistic is that we give both drugs, but they have a much higher response to the fact that we're giving them together than we necessarily predicted. So what this is additive is predictable. Right? You give an antihypertensive, something that's going to lower blood pressure, and you give another drug that lowers blood pressure, we expect to see the combined effect of both, right? We're going to lower blood pressure by both of them. In a lot of ways, synergy is unpredictable. Because we can't account for two drugs being given together and them having this wild effect that is greater than either one of them alone, right? And then potentiation is where you have your drug, so it lowers blood pressure, and you have a different drug that you give to the body that, maybe it's an antibiotic for whatever reason. And an antibiotic should have no effect on blood pressure, but for whatever reason, when you give the active drug and this inactive drug, you get this increased effect, which again is unpredictable for the most part. If there's a drug interaction, maybe we can account for it. But again, we don't expect something that has an effect to have an effect. So when we look at what's going on here and we look at the responses, we can kind of extrapolate this idea a little bit. So drug A appears to be at about 50%. I didn't draw this very well, but you can forgive me that I was attempting to go for about 50. I think we can all agree that the combined is at 100. And what I was trying to show was that the other substance was at 0. So we have a drug that gives no effect plus something that does have an effect equals more than what we were expecting, right? 50% plus 0 should give us 50%, but somehow we ended up with much, much, much higher. So this would be an example of a potentiated, exactly, a potentiated relationship. Does that make sense for people?
Yes.
Okay. Let's say that we can also extrapolate numbers into this as well, right? So let's say that we had an active substance that gave us a 30%, that's too dark, too late, 30% and 50%. We should expect an additive effect of 80%, right? So just because it's one, what this is essentially saying here is that 1 + 1 = 2. It's predictable. We know that 1 and 1 = 2. The difference would be we give 30 and 50, and somehow we get 100. So 1 + 1 should be 2, but somehow we ended up with 3. So don't get stuck into this idea that it has to be 1 and it has to be 2. It's just this idea that it's a predictable response versus an unpredictable response. same thing here, that we expect that 30 plus 0 should equal 30, but somehow we ended up with 100, for example. The other thing that we can say from this graph is that we have a left shift, right? We give drug A alone, and we give it with this other substance, and we see that our graph is slided to the left. So the question becomes, is drug A more potent when it's administered with this other substance? Is drug A more potent in combo? Yeah, it would be, right? Remember, potency just is all about the x-axis. So it's, the fact that we can administer lower doses for the same response means that it is more potent. So yes. Is drug A more effective in combo?
Yes.
Yeah, it would be, right? So just like how potency follows the x-axis, efficacy follows the y-axis. So because the maximum effectiveness of the drug increases, we can say that in combination, it is definitely more effective. So these are the sorts of questions that you should be expecting on the exam. Things about relationships, more potent, less potent in combo, more effective, less effective in combo. And it really comes down to being able to manipulate these variables and being really comfortable with these variables. And when we look at the practice questions, you'll get more of a feel for how he's going to ask them. When we're comparing one drug that is at 0 with another drug that is more than 0. Yes. Yep. So potentiation is where you have inactive substance. So in order to be inactive, you have to have no effect. Because even if you have a minimal, 1% effect, you're technically an active substance. And then you would cause it to either add or synergize or something like that. Yes, potency follows the x-axis, efficacy follows the y-axis. No problem. All right. Next graph I want to look at. Reversible versus irreversible inhibitors. One of the things that can happen for an antagonist is that it binds to receptor or an enzyme or something and shuts it down. So it binds to the receptor and prevents activation. I think the best way of explaining this is with an example. And so what we have to work with is the COX enzyme, which takes, I'm pretty sure it's arachidonic acid. I'd have to double check. It takes a arachidonic acid and converts it into prostaglandins, I'm pretty sure. I'll have to double check this in a second, which are pro-inflammatory propane molecules. So if the COX enzyme is working and you hurt yourself, then you will be in pain. What we can do is we can administer an NSAID, which comes in and inhibits the COX enzyme. So it works as an antagonist. Not every NSAID is created the same way. When we look at the actual COX enzyme, it has an active site. So maybe its active site is down here. And what should happen is that the arachidonic acid comes in, it gets, kerchunked through the COX enzyme and gets turned into a prostaglandin, which then creates pain. What an NSAID would do, and other antagonists like it, is that it sits in the active site and it does competitive inhibition. Which is the same thing as saying competitive antagonism. Inhibitors and antagonists are often used interchangeably in terms of vocabulary. Most enzymes have a separate site on them that is a crucial part of the tertiary structure of that enzyme. Could even be the receptor. It doesn't really matter what it is, but some part of them that it is specifically oriented so that way the enzyme or receptor, or whatever it is, works correctly. Some drugs are able to bind into this other site. And I'm trying to remember the name of that other site. And I know it's like right off the tip of my tongue. I want to say alimentary, but that's wrong. The allosteric site. That's where it is. And so often what happens is you can have non-competitive inhibition that deactivates the enzyme outside of the active site. So you have two different kinds of inhibition or antagonism, competitive and non-competitive. Are which is a non-competitive one? Oh, okay. Now I see what's being asked. Yes. Okay. So when we look at competitive versus non-competitive, one of the things that is big to understand is that at the active site, you have the drug and you have the endogenous ligand. So in this case, arachidonic acid. And both of these guys are trying to bump their way into the receptor, right? And so if the drug is suddenly in the receptor, what's stopping a molecule of arachidonic acid from coming in and kicking it out? Nothing, right? So by virtue of what this is, by virtue that you have two substances competing for the same location, competitive inhibition is reversible. Compare that with the allosteric site or non-competitive. Is arachidonic acid going to come in and dislodge our drug? No. It's going to the active site. So non-competitive inhibition is irreversible because you do not have two substances competing for the same spot. Does that make sense for everyone? Okay, sweet. One of the confusing graphs that's in the packet, which is page 27, are, whoops, these two graphs here. And what both of them are measuring, once again, is we are looking at the dose of the agonist. So along the bottom, we have dose, and along the y-axis, we have percent effect. And just like we expect, and as we saw earlier, as you administer more and more of an antagonist, the potency of the drug goes down, right? Or the amount of the drug that you have to administer goes up and up and up. What does not change, though, is the efficacy of the drug. If you give enough agonist, if you pump that patient full of drug, you can overcome whatever is in their system, right? At some point, you can administer enough that it will overcome any antagonism. And essentially what that is saying is that because the drugs are competing for the same spot, we can always increase the amount of the agonist to overcome antagonism. And I think the best thing to explain this with is that's a different example. Compare this with irreversible. Irreversible inhibitors do in fact decrease the efficacy of the drug. Because as you administer more and more antagonist, you are disabling more and more of the receptor. Exactly. Tug of war is reversible versus irreversible is like I've just like cut the rope in half. Or I keep cutting it and saying you're not allowed to play. So one of the hard parts about using irreversible inhibitors is what happens if you overdose someone on an irreversible antagonist? What happens if they overdose on an antagonist? What would happen?
They're not making it to Christmas.
Yeah, they very, very bad stuff, right? So no matter how much agonist we give in order to counteract that overdose, nothing will happen. The receptor is completely disabled until the body regenerates new receptors. So until that cell, internalizes the receptor, destroys it, and makes a new one. What happens if someone overdoses on a competitive antagonist?
You can always fix that condition.
Yeah, in a way, we can just keep giving more of the agonist, right? We can work against it by giving more and more and more and more of this. So some examples to kind of keep some things in your mind is that you guys have probably heard of the drug omeprazole, Prilosec. Omeprazole is an irreversible, unfortunately, omeprazole is an irreversible inhibitor of the proton pump. Proton pump inhibitor. If someone takes too much omeprazole, they completely turn off stomach acid production, which can be really bad because we need stomach acid. It can, leave them vulnerable to, bacteria. They're not digesting correctly, a whole bunch of different things. You cannot administer an antidote to omeprazole. You have to wait for the body to redo it. Compare this with something like with I don't know why you would do loperamide, which is Lamodal, used for constipation, and it's a peripheral mu antagonist. If someone overdoses on loperamide, we can give them a agonist in order to reverse the effect of loperamide. Is it an antagonist? I'm pretty sure it is. Opioid. Or maybe I'm misremembering my drugs. Anyways, the name of the drug doesn't matter. We are just looking at examples. I don't think it's loperamide, but I can't remember the drug off the top of my head. So I'm going to leave it and we're just going to move on. All right. Let's talk about the last stuff in the packet because I believe we have covered all the other content. All right. So, did Keel say he's going to test you on metabolism and elimination? Or did he say MedChem is going to do that? I'm not going to test you on it. Or did he just say if it's in the packet, it's fair game?
Yeah, as long as it's in the first packet, it's gonna test us on it, so.
Okay. Probably fair game. Okay. Not a worry. All right. When we look at when a drug enters the body, we've already talked about absorption. We have to talk about distribution, but what's most important, especially in pharmacology, is metabolism and elimination. I'm not going to spend a whole lot of time talking about this because it's sort of straightforward the way he explains it. And he'll go into way more depth later on in the semester. But there are a few specific points that I want to reiterate for you. In terms of metabolism, the majority of metabolism occurs in the liver, with some of it occurring sometimes in the kidneys, sometimes in the lungs. Really, it can happen anywhere in the body. Sometimes it's the cells that line the GI tract. The majority of it is happening in the liver. And what's very, very important to understand is first pass metabolism, which is the idea that when ingested substances enter the body, they go into the liver first, are detoxified, and then can enter the blood. So what I mean by that is that you eat a drug, you eat the drug, it is going to go into the GI tract, and at some point is going to get absorbed into what's called the splanchnic veins. Pretty sure it's the splanchnic system. What's really important about this is that the drug goes through what's called the hepatic portal vein and enters into the liver. It then goes through the process of metabolism. Goes through the hepatic vein, and is finally dumped into the general blood circulation. So you eat the drug, it goes into the GI tract, it gets absorbed and enters into the liver first, where it is metabolized and then leaves the liver and gets dumped into the general blood. Some drugs are how can I say this? Not all drugs are treated the same during first pass metabolism. Some drugs are highly metabolized, while other drugs have very minimal amount of first pass metabolism. In general, what we say is that the administered dose, let me explain it this way. First pass metabolism dictates bioavailability. So if I give 100 milligrams, send it through the liver, so I eat it, it goes through the GI tract, gets absorbed into the liver, where first pass metabolism occurs. And I can measure the percent of drug that is left over after that metabolism. So what we can say for a drug like this is that I would have 50% bioavailability, which is 50 milligrams, so what we got out of it, divided by 100 milligrams, what we put in. So the amount of drug in the blood over the oral dose. You can have some drugs that, like lidocaine, for example. Lidocaine has a 99.8% first pass metabolism rate, which means that only 0.2% of the drug is actually entering the body. So a couple of points to bear in mind. If you have a low first pass metabolism, then you have a high bioavailability. So if you give 100 milligrams, it goes through the liver. You get out 99 milligrams. I will answer that question in just a second. So high bioavailability is a low first pass metabolism. What would be the preferred route for drugs that have high bioavailability? How should we give a drug that has high bioavailability? Oral. Exactly. If eating the drug isn't going to affect how much it enters into the body, then just give it orally. In contrast, if you have a high first pass metabolism, that means you have a low bioavailability And so what would be the preferred route here? Transdermal or IV? One of the vocab words you will hear often is that because oral is entering into the gastroenteric tract, right? We call this enteral. So it's entering the intestines, the enteral system. So it is enteral. Whereas outside of the GI tract is called parenteral. Parenteral. So any method of administration that is outside of the intestines is parenteral and avoids first pass metabolism. So just like Sarah says, this also includes sublingual, buccal, nasal, inhaled. As long as you're not having it being absorbed through the intestines, it is avoiding first pass metabolism. So all of these other routes avoid first pass. So here's a question for you. Should the dose of a drug with a bioavailability of 0.95 be kept the same as IV administration? And I'm actually going to change this number to, no, I'll keep it the same. I'll keep it the same, 0.95. This would probably be easier to explain. And then I'll give the other one. Should the dose of drug with a bioavailability of 0.95 be kept the same as IV administration? Depends, no, yes. So this is it's a challenging question because it's something that you guys probably haven't encountered it yet. So if you're like, I have no clue, that's totally fine because this was probably something you haven't seen yet or had someone explain to you. So let's talk about it. Remember that bioavailability, or F, is the amount of drug in the blood post first pass metabolism versus the drug given orally. Milligram. If your bioavailability is near 1, then the first pass metabolism has a minimal effect. So if I give 100 milligrams by mouth, I'm getting somewhere near 100 milligrams in the blood. What happens if I give that 100 milligrams by IV instead? I get 100 milligrams. So I'm getting about the same dose. So if I'm administering 100 milligrams versus 95 milligrams, is that close enough where I don't have to go and compound a new dose for IV? Probably. It's within an acceptable margin. So if you have a drug that has a very, very high bioavailability, we can also say, in a way, high bioavailability is that there is no difference between oral or parenteral administration. Is there a general cutoff? It's different for every drug. But I would say if it's 95% or higher, he would give you a bioavailability of something. He would give you the opposite of this question, actually. Oh wait, should the dose of the drug be kept the same? Yes, dose of the drug should be kept the same. What he would probably give you on the exam, if he was to ask a question like this, is should the dose of a drug with a bioavailability of 0.18, I'll make it easy, 0.15, be kept the same as IV? So should the oral and the IV dose be the same for a bioavailability of 0.15? I would say no. And let's take a look. So if you gave it orally, we gave 100 milligrams, how many milligrams would come out after? Well, all we have to do is multiply by the bioavailability, and we can see that we get 15 milligrams out. If we did it by IV, IV administration always has a bioavailability of 1. So look at these dose differences. So you're administering almost 10 times the dose, right? No good. So would you keep these doses the same? No, you would not. You would definitely have to reduce the IV dose. Which question is he going to most likely ask on the exam? This one down here, the one with the low bioavailability. The reason why is because the cutoff, 95% versus 97% versus 99% is different for every drug. But definitely anything below 50%, you're not keeping the doses the same. You are most definitely going to be you are most definitely not going to be keeping them the same. Why is it 100 milligrams? It doesn't necessarily need to be. So let me ask another question. Should will the dose of 17 milligrams of atropine bioavailability equals 0.47 be higher or lower than its inhaled dose? potentially higher. No worries. We're going to do the same sort of calculation. So once again, we say oral. What is the dose of the drug? 17 milligrams. Why did I choose 100 over here? Just to make the math work out nicely. But I'm being told 17 milligrams. And what I can do is I multiply this by the bioavailability in order to get the actual dose of the drug that enters into the body, which in this case would be near 8. If you were doing it inhaled, what would the bioavailability of an inhaled drug is 1, right? Because it's not going through first pass metabolism. It's bypassing the liver. And so the bioavailability is 1. And so we'd see that our blood concentration would be 17 milligrams. So is the oral dose of atropine higher or lower than its inhaled dose? Higher or lower? Lower. Exactly. If it's outside of oral, it's 1. That's my bad. I probably should have put oral here. Will the oral dose be higher or lower than its inhaled dose? Any questions about this? All right. Let's talk about metabolism, even more metabolism. All right. Please draw me the following pentapeptide. Guys, remember how to draw pentapeptides? All right. So the majority of drug metabolism happens through a group of enzymes called the CYP enzymes, so cytochrome P450 enzymes. And there are a whole bunch of different cytochromes. They all do different things. They all have their specific role in the body, but we can also look at the number of drugs that are affected by that specific. Nope. These are the ones that are affected by acetaminophen, definitely. So what you can see is that of the enzymes that do metabolism, half of them are the P450s. There are other enzymes like UGT and hydrolase, but the majority of the work is being done by these very, very, very complex cytochrome P450 enzymes. What we can see is that it's not just one enzyme that is doing all the work. You'll hear a lot about CYP3A4. CYP3A4 does a ton of heavy lifting in the body. It affects a ton of drugs. But we also have other enzymes that focus and affect drugs. So fentanyl, yep, is one of them. So basically what this is saying is CYP3A4 affects 22% of the drugs, CYP2E1 24.8. That's kind of high. I think this is a better. I want like a. No, I guess that is. I don't like the graph. I don't know what it's saying. But essentially what it is that 3A4 does a ton of heavy lifting in the body. Because of that, we can look at changes in the enzyme and see exactly how those changes would affect our metabolism. So for most drugs, they go from their active form to inactive metabolite. Or at least that would be the goal. You go from an active drug into an inactive metabolite. It leaves the body, bish, bash, bosh. We're all good. Bish, bash, bosh. Not all drugs, or before we go into that, for the most part, the active drugs are going to be lipophilic. Otherwise, they wouldn't be able to enter into the different membranes and tissues that they need to go to. And it should have a high affinity for the receptor of interest, right? So it goes to where we want it to go. In general, inactive metabolites are hydrophilic, so that way they can be excreted, usually by the kidney, sometimes by the liver, through the feces. And these have what I will say lower affinity. Sometimes metabolites do have affinity for the receptor, but it is almost entirely lower, much, much lower. Some drugs have very, very, very low bioavailability when they go through the liver. What we do is in these cases, we administer what's called a prodrug. And what these prodrugs do is that they go through first pass metabolism, they go through absorption because the active drug itself is not able to do it. So maybe it's too hydrophilic to really be absorbed. Okay, make it into a prodrug. Maybe it goes through such high first pass metabolism that it would have such a low bioavailability. Use a prodrug. So there are lots of different reasons why we would benefit from a prodrug, but the overall usage of them is so that way we can get the prodrug to enter into the body, go through some sort of metabolism, and then have the active drug come out the other side. What's important to know is that the enzymes that usually cover metabolism that turns it into inactive metabolites, they do. An example would be like enalaprilat. which gets converted into enalapril. Another one, which you have probably heard more of, is codeine, gets converted into morphine. So the enzymes that cover the active drug becoming an inactive metabolite are the same enzymes that usually metabolize prodrugs into their active drugs. Maybe this is handled by CYP3A4 and this is CYP2D6, but for the most part, we're talking about the same collection of enzymes. Exactly. The role of a prodrug is to protect the active drug. Or to facilitate absorption. There really are two reasons. There's a couple of more, I'm sure, as well. But really, it's either to protect it or to facilitate absorption. Now, some drugs also metabolize into active metabolites. But what's important to note here is that they are still more hydrophilic than they were before. But in this case, they may have varying affinities. Does that have to do with delayed release tablets? Delayed release tablets are more about wanting to control when the drug gets released in the body. So if we administered a drug and let's say it gets destroyed in very acidic conditions, like the stomach and the duodenum, then we would use delayed release to make it happen like towards the jejunum or the ileum, or even the colon. For drugs that are too hydrophilic, we would use a prodrug. Yes, because a hydrophilic drug will not absorb. It can't go through the membrane in order to get absorbed. That would be more using like different excipients in the tablet to help with dissolution. What I will like a salt or something like that. But really for the most part, the issue is the lipophilicity. It's harder to get it absorbed than it is to get it to dissolve. Stomach acid does a good job at that. All right. Let's take a look at a specific example. Or actually, before we do that, I need to talk about polymorphisms. Some people are different. And these different people have different, these different people have different numbers of enzymes. Yes, pharmacogenomics. Huge, huge part of pharmacy, especially nowadays. What's important to know is that when we talk about pharmacogenomics, it's not necessarily that, oh, someone has an enzyme that works better. That's not really how pharmacogenomics works. What really is happening in polymorphism is a change in DNA. Polymorphism. A change in DNA that changes the number of enzymes. So in other words, everybody pretty much has the same enzyme. You, me, everyone else. Yes, this is related to SNPs. Everyone pretty much has the same enzyme. The difference is that some people have more of them than others. And what we can say is that people who are faster metabolizers generally have more of those enzymes. So slower metabolizers have some sort of mutation in their gene where the action of the enzyme is reduced. Compare this with rapid metabolizers, where the action of the enzyme is increased. And then, of course, you have ultra slow metabolizers and ultra rapid metabolizers, which are, even slower and even faster than everyone else. What can happen, though, is depending on what kind of drug we are, you can end up with different effects on a drug. And I want to look specifically at codeine. Oop, that is too small. A little bit better. Here's codeine. So codeine, if people don't know, is a opiate. It's usually used for cough suppression, but sometimes it can also be used for pain, although very unusually nowadays. What ends up happening is codeine, 90% of codeine goes through N-demethylation. So they take this methyl group on this nitrogen here and removes it, pops it right off. Boop. This is norcodeine, I think, which is an inactive metabolite. It doesn't do anything. About 10% of codeine, however, is sent through CYP2D6 into morphine, which is the actual effect of codeine. So if we want the anti-cough, anti-pain effect of codeine, which enzyme do we prefer, 3A4 or 2D6? We want 2D6. So what we can do is let's map this out a little bit. We have codeine, which is, for all intents and purposes, going to be our prodrug. And codeine is metabolized via 2D6, 2D6 into morphine, which is our active drug, or it can be inactivated via 3A4 into its inactive metabolite. Is everyone with me so far? Any questions about this? Okay. In a normal person, they convert codeine to morphine at about a ratio of 10%. Let's say that we have a person let me say this is the use of, put it this way, the reason why we use codeine is for anti-cough, anti-pain. The side effect associated with codeine is CNS depression. So like you get really, really, really sleepy, and respiratory depression, meaning that your ability to breathe is decreased, among other things. So the question I have for you is this. What would someone feel if they took codeine for pain, but was an ultra slow 2D6 metabolizer? What would someone feel if they took codeine for pain, but was an ultra slow 2D6 metabolizer? Would they be in pain? Would they not be in pain?
It
Would
would
they...
be like
So,
so unusual.
Yeah, so let's break it down by the use, and then we'll talk about side effects as well. So would they be in pain, or would they have pain relief? What would we say?
More pain? Question mark.
I'd say that they would be in pain. So we're using this for pain, right? This is the use. But if we are a ultra slow metabolizer, let me back up. Let me erase this. If we are an ultra slow metabolizer, are we going to have more morphine conversion or less morphine conversion? Less.
Less.
So if we have less morphine conversion, are we going to have more or less pain relief?
Less pain relief.
Less pain relief. I wouldn't say that we're causing more, he would be in more pain. We're not breaking his leg, but we're definitely not relieving it at all. So less pain relief. Don't punch your patients. So in other words, an ultra slow metabolizer is basically turning this off. The effect of the enzyme goes down. So instead of 10%, maybe it's 1%. Would they have or let's ask a different question. What side effects would someone have if they were a rapid 2d6 metabolizer and they took codeine? So they're taking codeine for pain. What side effects would they have? Or maybe the better way of saying it, would they have more side effects or less side effects?
Would it be more side effects since there is more morphine in the system?
Exactly. So we're having more morphine conversion. Which means more side effects. And like some people also said, we're having more pain relief. Does this make sense for people now that I kind of walked through it? Okay. Is codeine a good option for someone who is a slow metabolizer at 2d6?
No.
No. Bad option. And this is the power of pharmacogenomics, right? Would you ever want to give codeine to someone who needs it for pain and they have a slow metabolizer? No, they get no pain relief. Would you give codeine to someone who is an ultra rapid metabolizer? You could, but what would you have to do to the dose?
Would increase it? No.
Well, let's see. So if you have someone who is an ultra rapid metabolizer, so let's say that they're at 50% conversion. Now, normally 10% is what happens. So if I give let me put some colors in here so that way we can. So normal 10%, ultra rapid 50%. I said I was going to put in a color. Ultra rapid 50%. So normally, if I gave someone 100 milligrams, they're getting 10 milligrams of morphine, and that is, a good amount of morphine for their pain relief. This is studied. We figured out, oh yeah, 100 milligrams of codeine, that's enough because you only need 10 milligrams of morphine to get some pain relief. Compare this with the ultra rapid metabolizer. They're getting 5 times the amount, right? So we would definitely have to reduce the dose for rapid metabolizers. Yeah, so we give them, so that's a very, very good point, is that are they clearing the drug faster as well? Which is what you will explore in kinetics, because just because you are a faster metabolizer doesn't necessarily mean that it leaves the body quicker, because it still needs to get to the liver. That has to do with volume of distribution and kidney function and blah 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 blah. All right, I want to look at another example using this same sort of principle. You have atorvastatin, which is the active drug, and it is metabolized via 3A4 to its inactive metabolite. Atorvastatin, does anyone know what atorvastatin is used for? Anybody remember from Thera last year? Oh no, what did you guys say? It is cholesterol. Very nice. It's used to lower cholesterol. And does anyone know some of the side effects of atorvastatin? Or the big one? What's the one we always watch out for? Edema, not a bad idea.
Does it
Something
have to do
called
with weight? No.
not weight. What can happen for some people is they get muscle pain, and it's because their muscles are literally breaking down. So the drug causes their muscles to break down, and so they have lots of back pain, and it can lead to a very, very serious condition called rhabdomyolysis, which causes your kidneys to completely fail, and you're fucked up and different stuff like that. So you give someone atorvastatin, it's always very, very important to tell them that if they have any back pain, they have to go tell their doctor immediately, because it can progress pretty quickly. What would happen to or what would how do I want to phrase this? Would the cholesterol lowering effect of atorvastatin increase or decrease in the presence of a 3A4 antagonist? Would the cholesterol lowering effect of atorvastatin increase or decrease in the presence of a 3A4 antagonist? Increase, decrease, some people, let's say. So the difference here than what we were looking at before is that codeine was a prodrug, right? Had no effect on the body. Here, the active drug is prior to the metabolism. So if you give an antagonist is going to turn off 3A4, meaning less of the active drug is being metabolized. So more atorvastatin collects in the body. And so if more is there, then you're going to lower the cholesterol even more because, it's not being metabolized. It's not being removed from the body. So would the cholesterol lowering effect of atorvastatin increase or decrease? It would increase. And the reason is because we are turning off metabolism prior to getting rid of the active drug. And then the question would become, does the risk of back pain increase or decrease with an inhibitor? It would increase. Yep. Increase because more of the active drug is hanging around. Any questions about why this is a different setup to this diagram? So here we are talking about 2 enzymes. Here we are talking about 1 enzyme. All right, last question I have for this, and then we'll spend some time looking at questions because I said we were going to look at them and then time flew. Would the dose of atorvastatin increase or decrease if a patient was also taking a 3A4 inducer? So a enzyme inducer increases the action of that enzyme. So speeds it up, makes it more effective. So would the dose of atorvastatin increase or decrease if a patient was taking a 3A4 inducer? Increase, decrease. Let's see. So let's say that under normal conditions, we give 100 milligrams. And I don't know what the bioavailability of atorvastatin is, and it doesn't really matter as long as I use the same number. So let's say that, once it goes through metabolism, its F is 50%. Oh, no, we're not talking about bioavailability. Blah, 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 blah. Let's say that the enzyme is, every hour it chips away 25% of the drug. So after 1 hour, 75 milligrams is left. An inducer is going to make that process faster. So if we had 100 milligrams, it's going to increase the action of 3A4. So maybe now we only have 50 milligrams left after it goes through the enzyme. So it's almost like we have an ultra rapid metabolizer. So an inducer is going to increase the action of the drug, meaning that more of it is going to exist as an inactive metabolite, which means that we need a higher dose of atorvastatin in order to counteract the inducer. So once again, if there's an inducer, it's going to increase the action of atorvastatin, increase the action of the enzyme. which means more of the drug is going to exist as an inactive metabolite, which means that we need a higher dose in order to counteract it. This is very different than what we talked about before, right? Where we needed to give a lower dose in the presence of an ultra-rapid metabolizer, right? So it depends if the active drug comes before or after the enzyme. And why drawing these diagrams on the exam is going to be very, very, very important for really understanding what they're asking. And a lot of the questions are going to be something like, you have a active drug that is metabolized into inactive metabolites. Okay, active drug metabolized into inactive. So that would be something like this. But any questions about this before we take a look at some questions? Yes, I will definitely post them. Yep. Just to show you what I was talking about. Timmy has been prescribed hydroxychloroquine for his arthritis. This drug is metabolized by CYP3A4 and 2D6. Pharmacogenomic testing reveals that Timmy has extra copies of both the 2D6 and 3A4 genes Timmy is likely to have. So what I would say is, first, draw a diagram of what of the situation. And then take a look at what the effect would be. So I'll give you just a moment. What is POG? I see it every so often. You young kids in your lingo. It means based. What is based? What is based? What's BBAG? Bashash. Answer the goddamn question. I'm not Googling. Oh, okay. Answer the question here. Timmy's been prescribed hydroxychloroquine. See, let's take a look. So he is given hydroxychloroquine, and it is metabolized by 3A4, and it is metabolized by 2D6. Based on the genetic testing, he has extra copies of 3A4. And we should fill in into most likely inactive and inactive. The only time you would have an active metabolite is if they tell you specifically in the problem into active metabolites, or it's a specific drug that he has given you in order to memorize for the exam, like codeine and morphine. So if you have hydroxychloroquine and you have extra copies, then that means that more of the drug is being converted into inactive metabolites. So what would happen to our concentration of the drug, this would go down. At the same time, then the amount of inactive metabolites would go up. And so if you have less drug hanging around, that means you have a smaller effect. So it would be C. Any questions on this? All right. Do number 10. CJ has started on nortriptyline for depression. Nortriptyline is metabolized by the enzyme 2D6. He noticed that it is not effective and goes in for blood work. His concentrations are really low. What can you suggest about his blood levels of 2D6? Look up based. What is based? Based is a slang term that originally meant to be addicted to crack or cocaine, or addicted to crack cocaine, but was reclaimed by rapper Lil B for being yourself and not caring what others think of you to carry yourself with swagger. You kids are weird. You are weird children. Ignore the addiction part. I'm in substance use and addiction. That's my field that I work in. I can't ignore it. All right. So you have nortriptyline, which is being converted via 2D6 into inactive metabolites. What we have found through his blood work is that he has very, very low amounts of nortriptyline, which means that more of the drug had to be converted by the enzyme. And so what would his blood levels be? They would have to be increased in order to get rid of the nortriptyline. If he gets his pharmacogenomic testing back, what would be his kind of metabolizer? Fast? Are we sure? Are we sure that it's fast? Yes. Yep, he is fast. Remember that we are talking about the number of enzymes. So it's not faster because the enzyme is working better. It's faster because we have more enzymes. There isn't an answer key for this one, but oh, but for what you said, Jana, fast because the levels of nortriptyline dropped. Yes, that is true. That is a true statement. Also, is there an answer key for this? It doesn't look like there is one on the Blackboard, so I'll make one. So you guys can have that. All right. Mary has recently been prescribed enalapril for hypertension. Enalapril is a prodrug that is converted to its active form via CYP3A4. Mary has very low levels of functioning CYP3A4 genes. What is she likely to find out when her doctor follows up and checks her blood pressure? Also, do you guys now see how these questions about like metabolism are going to be asked? Does this make what we talked about earlier much, much clearer? Okay. That's always a question that I would get is how do I know what to draw for the diagram? And yeah. All right. So Mary is prescribed enalapril, which I realized that I when I talked about it earlier, enalapril is the prodrug and enalaprilot is the active drug, I guess. Enalapril is a prodrug that is converted to its active form via CYP3A4. So we have enalapril, which is converted to its active form via 3A4. What do we know about prodrugs? Are they active? Are they generally inactive? What do we know about them? For the most part, they are inactive. So if Mary has low levels of functioning 3A4, then the effect of 3A4 goes down, which means that very, very little of the drug is converted into its active form. Now, what is the effect of this drug? What are we using it for? We're using it to lower blood pressure, right? She's using it for hypertension. So if we're not converting it to its active form, we are not lowering her blood pressure, which means that it will be elevated or the same. It definitely won't be lower, I guess is the way to say it, right? It cannot be lower. If you are not converting the drug, so 3A4 is not working, does that mean that the levels of the active drug are higher or lower? These would be lower, which would mean that the prodrug is higher. And so the answer is D. Would this be, or my question is, why is it not B? Exactly. Just
Because
is, go ahead.
I was just gonna say because there's less side effect um of the active component, so the blood pressure would just stay the same.
Exactly.
Like you would.
This drug is inactive. Is it going to cause blood pressure to rise? No, we don't know that. Just because we don't give her a drug to lower her blood pressure doesn't mean that her blood pressure suddenly goes up, right? It's going to stay elevated. So it's inactive. It's not an antagonist, which is, it's inhibiting lowering, which would be the same as elevating, right? So does that make sense? So it would say the same. Tricky, right? Oh, here's the other one. Lower concentrations of active prodrug. Tricky. Added elevated blood pressure. All right, we will leave off here because we are over our time. Wednesday we will do all the practice problems I can find. I will make answer keys for anything that necessarily needs answer keys. Look out on the classroom for that. Slay the day tomorrow. And I will see you guys on Wednesday. If you have any questions or anything like that, please let me know. And if anything comes up, I will be around.
All right. Thank you, Gabe. Have a good night.